Welcome to the Health Leader Forge. My name is Mark Bonica, and I am an associate professor in the Department of Health Management and Policy at the University of New Hampshire. Today's guest is Dr. Neil Meehan, the Chief Physician Executive of Exeter Health Resources. Dr. Meehan is a board-certified emergency medicine physician and was the driving force behind the creation of the New Hampshire Physician Leadership Development Program, a joint effort between the New Hampshire Medical Society, the New Hampshire Hospital Association, and the University of New Hampshire. In this podcast, we discuss Dr. Meehan's own journey from living in a music studio above a peanut butter factory through medical school, residency, and his own development as a physician leader. We discuss in detail what the medical school and residency experiences are like because the New Hampshire Physician Leadership Development Program has a unique flavor based on Dr. Meehan's own experience of medical training, as well as his observations about how physician training creates some specific challenges for physicians who want to transition from lead clinician to clinician leader. I have been a part of the Physician Leadership Program since its inception, so it was fun to talk with Neil and capture some of the stories and insight that I have heard him share over the last few years. I hope you enjoy this interview, and if you do, won't you leave us a review on iTunes, Stitcher, Spotify, or wherever you get your podcasts? It helps other people find us. Thanks for listening, and here is Dr. Neil Meehan. Welcome to the podcast, Neil.
Thanks for having me, Mark.
So this is a lot of fun. We've been working together for a long time on a physician leadership training program that you founded. And I'm excited to talk about your thoughts on leadership today. And you're a physician, and you have some thoughts on the advantages and challenges of transitioning, of a physician transitioning to leadership roles. And you have talked, well, I've seen you talking to physicians who are endeavoring to take on these new roles, talking about kind of some of the learning that they have done, cultural assumptions, and kind of the hierarchical nature of medical training, and how that creates challenges for trying to transition into from a leadership role as a clinician to an organizational leadership role. Can you talk a little bit about kind of some of that, of your experience in medical training and how it shapes physicians thinking about leadership that you have looked at over the years to think about what do we have to unlearn or learn differently to make that transition to leadership?
That has been, I think, the focus of a lot of my career in developing physicians as leaders. And just to sort of start from the very beginning, we go through an apprenticeship. Mm-hmm. And that apprenticeship requires us to focus nearly all of our energy on the patient in front of us. And to be absolutely, the buck stops with you. I mean, that's what you're told. The buck stops with you. So don't trust anybody else's evaluation. I remember being on a vascular service, right? You know, a service that takes care of the arteries and veins of folks. And it's a tough service to be on because a lot of those folks have very chronic diseases, and the operations and procedures you do on them are high risk. And I remember rounding on a few, and and one of my jobs as the resident was to go and get all the vital signs. You're like the gopher. So you go and get all the vital signs, and I probably had 30 people, and the vascular surgeon comes over, and he says, "Okay, give me the vitals," and very curtly, and I kind of go, he goes, and I start spouting them off, and he said, "Did you take those yourself?" And I said, "No, I got them off the nurse's note." And he stomps his feet and goes, "So you just trust those? You didn't take them yourself? How do you know those are right?" And it was irrational. Even though I'm saying it right now, it was an irrational ask of me, because there's 30 people. I've been up all night, pounding out fires. And what he's saying is, don't trust anybody else. You need to go and take these yourself, and you're accountable for them. And I think it was an irrational comment, but that's what the subtext was. So, we're taught that the buck stops with you, that don't trust anybody else but your own clinical acumen. Don't get railroaded into thinking something's different when it isn't. We're taught that it's all about the patient in front of you, and you are the captain who needs to advocate for that one patient no matter what the cost, because that's your responsibility. So it's a very singular focus of your sort of career on a single patient. And I guess the other piece of it is that when you graduate from medical school, some of us are really well prepared, but some aren't, to have the top license in the room. And when you are managing a team of people, sometimes that license is, you need to say, we need to do X, or you need to exert your directiveness because you know what's maybe best for the patient. But that is at the expense of not allowing the team to fully inform you of what else might be going on. And so some physicians, I believe, use what I call the authority gradient to get things done. And that is absolutely necessary in some moments. And in many, and I would say most moments, that is something that is erosive of good team culture. And so we don't balance that very well when we get out, because that's simply not what we're taught. I would also say that even now, I think there's a lot of talk about educating physicians in team dynamics, leadership, emotional intelligence, team emotional intelligence. And although I hear and I read a lot about it, every time I get in front of residents, I'll ask sometimes, not every time, but most times I'll ask, how many of you have had education in team dynamics or being part of a team? And inevitably, I get one or no one who raises their hands in large groups. And so it lets me know that there's still a lot of the sort of traditional focus on being an apprentice. And so I think the difficulty then becomes when physicians are pulled out of the audience to be leaders. And in some ways, we're leaders of our clinical team, and that's almost always the case. So when you're in the OR, you decide what procedure is going to be done. You decide what treatment will be necessary. You decide the post-op care, and you decide when to discharge the patient. So you're leading that team. There's no doubt about it. But what the organization often needs is someone who can lead with a more broad picture of what the needs are of a department, what the needs are of a division, or maybe even what the needs are of the entire organization. And when we get out of our sphere of that clinical lead, we, I think, come to that position with not the right tools. So instead of someone who works through emotional intelligence and collaboration, you may be very used to using your authority gradient. So you run into issues with there, or rather than saying, well, we want to be focused on the safety of all of our patients, and how do you take a kind of a utilitarian view of that, instead of saying, no, we need to get this for this one patient right now, and it's hard for physicians to reconcile that. I think, and frankly, just some of the toxic lessons we've learned and we've come up through also come out in lack of collaboration, self-interest. And that is not to say that the personality of somebody is encompassing that. It's how they were taught during their apprenticeship. And so applying those tools to a organization and to team building and to building psychological safety and emotional intelligence and all of that that's necessary to run an organization, because you have to influence and change people, that needs to be learned. I'm not necessarily saying the skills of a physician need to be unlearned, but when they get thrust into a context of getting beyond their sphere of just the clinical team and into really broad teams that are meant to influence procedures in the hospital, or teams that are talking about patient safety or the patient experience. And when you get into those spheres of influencing other folks to change, then you can't bring those skill sets to that context. You will fail as a leader. And I will say that a lot of physicians get a really bad rap on leaders, on leading in those situations, because they haven't been taught the skills to lead in those situations, and they fall back on their what they know. And we've become known as hotheads. We've become known as obstinate, self-interested. Could go on about the different cliches.
Right.
But again, I think systematically that's how it's worked out.
I want to run more with that because I want to talk about your professional experiences post-residency, but I want to ask one more physician-specific question. And that is, when did you know you were a physician? So I mean, that's a huge identity it's a very important role in society. When did you feel comfortable looking in the mirror and saying, yeah, I'm Dr. Meehan?
That is such a interesting question. I mean, not a lot of people will ask that. Look, I was very uncomfortable when I was a doctor. When I graduated medical school,
right? Because technically you're a doctor. They hand you the degree. Congratulations, right. Dr. Meehan.
I was so uncomfortable. I said to people, no, don't call me doctor, call me Neil. and I look at that. It's not serving the patient, because it's almost saying, yeah, look at, I know you think I'm a doctor, but I'm really not. So I'm going to reduce the confidence in you that you have in me and create anxiety. It could have the opposite effect. But I was so uncomfortable with that I didn't understand, the gravity of maybe my own license. Yet I think that I would say it took me a good year to really have it sink in that everybody in my society, at least, looks at me as a doctor now. I mean, my identity, because I've been through this mental boot camp for 4 or 5 years, and because I've been so passionate about it, my identity is a doctor. I mean, you can call me a bad baseball player, or you can say I have poor taste in music. I'll debate you. Do not ever call me a bad doctor. That really, really pokes my identity, my id. And so I think many of us feel that our identity is, it's hard for me to even go in social circumstances without being called doctor. My nickname on my softball team is Doc Hollywood. Don't ask me why, but I'm just saying.
I get the doc part. I'm going to have to hear about the Hollywood part at some point.
I think there was some kind of comparison to some doctors on TV and blah, blah, blah. Okay. That's a whole other podcast, Mark.
All right.
I have trouble walking into parties. In all kinds of other social situations, even my neighbors. Hey, doctor, how you doing? Or oftentimes I'll even get introduced as a doctor. Mm-hmm. Even in music now in my band, like I have to keep telling the leader of the band, please stop introducing me as a doctor. I don't want to be known as that. And yet I think that's the expectation that society has on us, and I'm okay with it now. I'm kind of joking about the music thing, but I've learned not only to live it but to embrace it, and that's been a journey.
So you said about a year. Was there a patient encounter you had, or was it just kind of the accumulation of people looking at you and saying, doctor?
Yeah, that's another great question. I don't think I have a good answer for that, Mark. All I could say is my recollection is I remember the anxieties of it when people were calling me doctor, and I remember me saying, no, don't call me doctor. I feel more comfortable with it. I would say that it was like osmosis, and eventually it became my own internal culture. And then I would say sometime probably by 2 or 3 years, I was solidly embracing my identity. So I don't know if there was a seminal moment.
Okay. So you graduated from UMass and began practicing at Lawrence General Hospital in Lawrence, Massachusetts, as an emergency medicine physician. And you were there for a number of years and from my understanding, pretty rapidly moved into leadership roles, ultimately serving as the chief medical officer for the hospital. Tell me a little bit about kind of your evolution and when you made that transition from being a clinician to wanting to take on leadership roles, and kind of how did you wind up being the chief medical officer?
Well, another long story that I'll try and make short, but basically, I did not go into medicine thinking I'll be in leadership or I'll be in administration, or even if I wanted to be a director. And I had influences. My father, he was chief of police by the time he had, retired. And so, I did sort of understand a little bit about the challenges of leadership, but we certainly didn't go into medicine for it. And I did have a penchant for change, and I was always one who was never satisfied with the status quo. And so what it led to me is going into the chief of emergency medicine at the time and complaining a lot about the way we did things, because I could see the inefficiencies. We knew they were inefficient, yet, it's like the paint peeling off the wall. Eventually you stop looking at it. And so I would be the one who looked at it and say, we need to fix this. And I don't think I was just going in to complain for the sake of complaining. I had some real improvements that I thought I could affect. And so if you complain enough, people will put you in a lead role if you're a physician, because they're just like, okay, this guy's interested. Maybe we can get some horsepower out of him, put him in that role. And so basically I became the assistant director, and I had been given some rote, like, can't get in too much trouble jobs, like do the schedule and a few other things. And then I did have a few projects I wanted to take on, and some of them went extraordinarily bad because although I wanted to fix things, I had no idea how to fix things within an organization. I didn't understand process improvement. I didn't understand change management. I didn't understand emotional intelligence of teams. And therefore, I probably tried to do it my way or the highway type of approach. Mm-hmm. And that got me into some hot water. And then I said, there's got to be a better way to do it. So there was a seminal moment where I learned, okay, I am ill-equipped to be in a leadership role. And how do I get equipped?
So you actually went and got a master's degree at Harvard in, I want to say was it public health, or with a focus on management?
Yeah, so I went to the Harvard School of Public Health for the Physician Executive, Development Program, which mm-hmm. I was blessed to. I feel so lucky to have gotten in there, and I was with some really, really influential emergency physicians and physicians from around the world. Because Harvard, it's such a sought-after program, and I was lucky to get in, and that was a transformational event for me. I really felt like not only was I educated, but I was applying it as I went, and that's part of the way Harvard works. You begin to work on projects in your home base right away, and with
so you were still at the hospital. Yeah, you were still at Lawrence, working full time and doing this at night,
and going to school. Yeah, and getting a master's degree too. I know. I'm a glutton for punishment.
Yeah, there you go.
And before that, I did have some. I did what's called the AMIA 10x10, which was the first thing that ever introduced me to organizational behavior, and that's a program that was started by the federal government. I was lucky enough to get a grant. It was only a 1-year program certificate. And I got it in biomedical informatics because I was really interested in EMR technology and whatnot. And so I had a little bit of leadership, but that was really where I learned about how to be a leader.
So what was it like? So you started learning these leadership skills. What was it like rising through the ranks in the same organization? I mean, you moved, for folks who are not familiar with this, you move from kind of departmental assistant, like assistant manager, all the way up to the C-suite as the chief medical officer. What was it like making those transitions through the organization? Was it challenging because people knew you as just a rank and file physician as you moved up, or was
Sure.
there an advantage to that, or kind of both?
Both. So, well, I think physicians have an added element of challenge or advantage that they need to display in order for them also to lead other physicians, which is, I do think you have to be respected for your clinical work. It's really hard. I mean, as physicians, we aspire to be great physicians. And we revere physicians who show tremendous clinical skills. And so if you are respected in your clinical skills, you are one step ahead when it comes to leading clinicians. And my route I took is I was a chief medical officer, a chief medical information officer first, and then chief medical officer. And I was leading physicians, basically. And so I think I had built up a good reputation of being a skillful clinician. And so that was a good step forward for me. I also I think I've had a good reputation for being a pretty emotionally intelligent person. So, sort of understanding the conditions of physicians and what they're going through, being a physician myself, and also being able to communicate and sort of, I think, have a general control over my own emotions during conflict and whatnot. I think I had some elements that were giving me an advantage in the beginning. I would say that definitely those skills were challenged when it came to really trying to hold my colleagues accountable. I think there was a very big challenge with the chief of one of the departments that I was immersed in almost immediately. I had excellent mentors at the time, which really helped me get my legs under me when I was really starting out pretty green in that CMO position. And I think that the challenges that were before me were exactly like you described. Look, I went from a colleague to really a boss and trying to hold everybody accountable who wasn't even in my department. I mean, that was really the biggest challenge. Is I can understand the emergency physician mindset. I understand their challenges and I've lived their experience. But when you go to hold pediatricians or surgeons or other folks accountable for providing high quality medicine, which everybody wants to do, but there's times when you need to correct a course, that was really difficult in getting my confidence. It took a few years to get into a mindset where I felt I had my own professional confidence to do that. And so that came with experience.
So while you were at Lawrence, you had kind of the seeds of what has evolved into the New Hampshire Physician Leadership Development Program that's sponsored here at UNH. What was it that made you start doing this course?
So what I realized, and this is the plight of many hospitals, that in the hospital I was at, prior to the one I'm at now, Exeter, mm-hmm. There was mainly a volunteer medical staff, meaning that most of the physicians who came and worked in the hospital were not employed by the hospital. They were there because it was their local hospital and they chose to do their work there. But they were small businessmen and women who worked out in the community and who had choice of coming to your hospital or other hospitals. And that's the way many hospitals work. And so those small business women and men, they are not beholden to the hospital, outside of the basics of safety and medical records and abiding by, OR times and all of that. But they leading a group like that is difficult. And also the previous administration had put no energy that I could see into building a physician leadership layer that I could delegate anything to. So what I ended up being was really a one-man band trying to lead a multi-million-dollar organization without any way to delegate or really stretch out the span of control, meaning that I had no bench of physician leaders to reach into that I could rely on. And that was mainly because the organization had not put any effort into developing them. And frankly, I'm not sure if the previous administration even believed in physicians as genuine leaders, at least from the administrative side.
Yeah.
So I said, I'm going to need to develop that bench because I can't live like this. I can't be the only person doing the work. I'm going to get a divorce. So I ended up really through a lot of work at Harvard designing, well, let me go backwards a little bit. Well, let me start from the beginning. I did look at third parties who really offer leadership courses. They'll do online courses. They will deliver the courses in person sometimes. But I found them to be pretty superficial, and I found them to be really expensive. And then you can send physicians to like leadership boot camp. But when they got back, they were really no better off because they had basically piled up all the emails. They had rescheduled their offices. And so when they got back, they were just inundated again with all the clinical work, and the leadership training had sort of dissolved. And so I didn't see a sustainable way to develop leaders in a way that was economically sustainable unless I just built it myself. And I felt like I had talent in the organization. And if I sort of brought a physician experience to it, then I could design something that would help me develop leaders and make it sustainable, and that they would give back to the organization. And that I just felt like there was a hunger out there for that, because at the same time, I know leaders were frustrated by the lack of engagement shown by administration. And so you had both sides frustrated with each other. And really the common link was to really provide leadership training and development for the physicians so that both entities would feel comfortable engaging each other. So I first designed a 2-year course that really I kind of focused on I would call them the sort of soft skills and hard skills. And I sort of focused on things like leadership, governance, quality, regulations, rules of medical executive committee. And what I realized is that what I really need is engaged team leaders and change agents. So over the course of a few iterations, the course rapidly changed to, I would say, a true leadership course where we look at ways to assess your personality and do self-reflection, and then build upon that and turn that into courses on emotional intelligence and how do you use emotional intelligence to influence people and to be more successful. And then how do you build teams with your emotional intelligence so that the team has a psychological safety, and then they can do great work together and they understand, how to interface with other teams. And then from there, build, because teams change things, how do you manage change in an organization, and how do you manage the emotions of change? And then from there, because change leads to conflict, how do you deal with conflict? Because frankly, physicians I find us to be a group who's fairly conflict avoidant. And so I guess what I'm saying is I really began to focus on the interpersonal and interrelational skills of physicians to train them to be better leaders. And then the second half of the course is really more about the hard skills, quality improvement. That's a skill every leader should really know deeply. And a big gap was finance, Mark, and that's how we met, where physicians are oftentimes, to be the ultimate leader, you want to be the owner and operator of your department or your division or your team. And that means you have to understand budgets and budget variances, and how do you create a budget? And then in order to understand, if you want to go and ask for I'm leading a change, but I need capital. I would like to get into robotic surgery. I would like to get to certain laser. How do you build a business plan around it? Like physicians, we don't get that type of training unless, of course, we had an alternate life before our training started. And so we also covered that base as well. And I think over the years, getting talented individuals to train folks to understand how to make it sustainable within their organization, how to build projects that are meaningful to both them and the organization. And then finally, we were one of the participants in the Mass Compass Awards. We were nominated for leadership and cultural change in Massachusetts. So at that point, I realized I was sort of onto something. And the other real outcome was that I saw the quality scores and the finances of the hospital begin to change for the better. And there were physicians leading efforts around the organization that cumulatively led to, I think, really great outcomes for the hospital. And it's hard to attribute all of that to just physician training, but in the areas of quality and patient safety, and I really think we made a big, big difference. And so when I came to New Hampshire, Exeter Hospital, we have great physicians, but there was not a lot of leadership development. I brought the program there. We had really successful cohorts. And by then the program, I think, was really honed pretty well. And then at that point, I sort of said, well, I talked to folks at UNH and at Mass Medical Society, and I brought together the Medical Society, UNH,
and New Hampshire Medical Society, right?
The Hospital Association, the New Hampshire Medical Society, the New Hampshire Hospital Association, and UNH. We got together and said, what if we created a sustainable program for provider and physician leadership in the state? And I was fortunate enough to have some pretty open minds. And there was some bumps along the way, and now we're into our third cohort, and I think it's going great. We've filled every cohort. So I really look towards the future of that as being, I think, a platform for the whole state to really create leadership capacity in the healthcare industry in New Hampshire.
Well, I've been excited to be a part of the program, and it's really great to get to know a lot of the physicians who are learning these skills, and they're really energetic, and it's a lot of fun to work with, very smart, motivated individuals. So you mentioned you came to your current role as the Chief Physician Executive for Exeter Health Resources back in 2016. Can you talk briefly about what is Exeter Health Resources, and what does a Chief Physician Executive do?
Yeah, so EHR is an umbrella corporation that houses three affiliates. First, the hospital, which is a 100-bed hospital in Exeter. The core physician group, which has, I think, greater than 180 providers now throughout the Seacoast area. And a large VNA called Rockingham VNA. Okay.
And so what's your role as Chief Physician Executive? And I understand it was a relatively new position when you took it on. What did the organization have in mind when they created the position and then brought you in to fill it?
Yeah, that's a really good question because I answer this a lot. I think people mix this up with a chief medical officer position, and I want to say there's a lot of overlap. So first, there are a lot of chief medical officers who are probably functioning as chief physician executives and vice versa. So the sort of Venn diagram is pretty overlapping. However, Exeter's case, what I know that they were looking for was a physician who could join the senior management team, who could be the voice of the physicians as far as getting their influence and input from a lived experience into the senior management team, and also helping with setting the strategy and the direction of the organization by, again, bringing in the skills of a physician who's also had leadership experience into the organization to add to the skill set of an already highly skilled senior management team, particularly given a few things. One is the onslaught of population health and risk contracts. So having experience in my previous organization, being in risk and being in an ACO and really working on population health, that was a skill set I think they were looking for. Also, to develop physician leaders, knowing that I had my previous experience with my leadership development. And then I think, honestly, the overall expansion and changing the environment of competitors who were entering left and right through different technologies, through different retail platforms. I think, the organization was ready to begin to look at a different strategy. And I'm glad they thought it was important to have a physician join them for that strategic planning. That, in essence, is what I do. If I had to say what are my three focused areas, it would be to really put us on the map for quality. I want to be recognized for quality. And as you know, we've been a 5-star Medicare hospital for over a year now. And that's been a great improvement. That's been a real feather in our hat. And also we've had a Leapfrog A score for more than a year. And so a lot of the quality goals that I had have come to fruition. On the other side, in the population health, I wanted to make sure that we were ready to join an ACO, which we eventually did. We also have taken on several risk contracts, which we've been successful in so far. And then I really wanted to begin to bring leadership development so that we could be a physician-led organization. I don't mean from an administrative physician-led organization, but that the organization can rely on physician leadership when it comes to managing teams for process improvement throughout the organization. And so building that strength is one of the other things I focus on every day.
What would you say are the skills and competencies necessary to become a chief physician executive of an organization like Exeter Health Resources?
I think that I've already mentioned a lot of the skills that we teach in our course. So emotional intelligence, understanding how to build teams, understanding your own ability to deal with conflict, because conflict, we oftentimes see it as something counterproductive, but when you get up to the level of senior management, a conflict is the culture in a way, and the conflict is productive, or at least in most teams that's what we aspire to make it. So understanding people's priorities, understanding where you have overlap in those, or understanding where you have differences in those, and then understanding how to manage conflict, even interpersonal conflict, is such an important skill, because there is not a day that I go through that doesn't involve some level of conflict. And I think through the years I've learned to embrace that, but I won't admit to trying to be or trying to say I'm any type of expert, and it's still something I'm learning all the time. And I think, a lot of the other things, those things you learn, I call it sort of through osmosis or through experience, those will come. The things like learning legal and regulatory nuances, and learning how regulatory bodies audit the hospital, and how strategy plays out. And there's probably a myriad of other things I can talk about, but a talented individual will learn those vicariously through the position. There's just simply no playbook for this. So I would say if you go with the skills that I mentioned, you've already set yourself up for success. And especially, you need to understand that your license as a physician gives you a certain credibility that nobody else has. And you can leverage that as a leader, as long as you're doing that in the context of what's best for the organization, high emotional intelligence, and understanding that collaboration and conflict, they go hand in hand. And if you approach it that way, you'll be successful.
So just to wrap up, so talking about what it takes to be successful as a chief physician executive, but kind of going back down the ladder a bit, what advice do you give most often to physicians who are making that initial transition from being a clinician, and granted, physicians are leaders in their own right as clinicians, but from that clinician role to the organizational leadership role? So what advice do you find yourself giving most often to people who are maybe taking on their first medical director job or something like that?
I would say, number one, find a mentor or find a coach. I think it can't be overestimated how important a trusted confidant who you believe is a good leader, who you want to emulate, at least, the skills of leadership, that you find someone who can interact with you and give you great advice on a regular basis. Just a good mentor goes such a long way in helping you in your own personal development. Number two is, I would say that treat leadership like you treat your own medical practice, that it's a art and a science, and that it is something that requires lifelong learning, and it's something that requires you to embrace as you do the passion of medicine. So finding moments where you can educate yourself in all those things I mentioned, change management and team building and good leadership. There's so much out there that's very accessible, but finding the time and the commitment to that, I think, is really important to develop yourself and your leadership skills. And then finally, I would say, be bold. If there's something someone is asking of you, give a lecture somewhere, or can you lead this team? That's a leadership moment. And I think you should embrace that. And a lot of us may not. They may feel, I'm not ready for that. Or, geez, maybe someone else is better in that position than I am. I would say embrace it, because that's the time when you're going to grow. And those are experiences that you are going to find priceless in aggregate as you begin to build your career in leadership. So those three pieces I'll leave you with.
I want to ask, me, my background is I was a comptroller, CFO type in the military system. When I look at physicians in leadership roles, I see a half of an FTE or a full FTE, a very expensive FTE. So sell me on why, as an organization, I should make that. If I'm not in one now, but if I was in a leadership, why should I pay for a half an FTE for a physician to move over to a leadership role? Because it strikes me as that's a big cost. So sell me on that investment.
So there's been several studies that have been out, and I won't say they're scientific, but they're mainly qualitative. But nonetheless, they come from really experienced organizations in the leadership realm. And I think what's clear is that when an organization engages physician leadership, or sometimes it's called when an organization is physician-led, they have better quality indicators. They do better in population health and risk contracts. They are more sustainable financially, and they grow faster than their competition. So physician leadership is an investment that I think is hard to measure in how many positive influences it will have on your organization. I would also say that it's not just an administrative leader that you get. It's someone who comes with proprietary knowledge of the field that you're actually administering. Knowledge that's been built over the course of 12, 13, 15 years. And for a physician to make the leap from their clinical journey in life to an administrative journey, that can be somewhat of a unicorn. And to embrace that and find out how to develop that, I think, is a blessing to any senior management team. So for those reasons, I think the investment in physician leadership is priceless in some cases.
So let me leave you with this. So you've been a physician since 1994. You graduated medical school in 1994. What's been most gratifying about your journey as a physician? The
most gratifying thing I've done is really everything I think I've invested in physician leadership. I think there's a thrill that I get when I am able to impact the careers of other physicians in leadership and know that I've set them on their own journey of developing themselves as leaders, because I know that effect, that ripple effect, will propagate throughout the organizations that they are involved in. And I think that's inspiring to me. That's self-actualizing to me. And that is the most gratifying thing that I do in my career.
Neil, thank you so much for your time today. I appreciate it.
All right. Thanks, Mark. Thanks for having me.
You've been listening to the Health Leader Forge.
Please go to our website, healthleaderforge.org, for more information or to leave comments about today's podcast. Look for Health Leader Forge podcasts on iTunes, Stitcher, SoundCloud, and other podcast distribution sites. Thanks for being a part of the Health Leader Forge community, and we'll talk with you again soon.